makes me feel smarter, but you don't need to, like, this is an open conversation, so don't feel like I'm going to preach at you. I have 96 slides, so I can get through those today, but no, I just want you guys to feel comfortable, and like as I hear the different things you're working on, make sure you ask me that stuff. Make sure that you got these questions in mind you like to leave with. I'd rather you get those answers than me give you another slide, okay? So help me help you to get that piece out. So let me give you just a little bit of background. You guys saw the agenda, so I'm not going to recycle that to you. But let me give you a little background on me just so you know the context that I'm coming from, so you sort of understand what I do, but then what I don't do. So I've been in the RTP area actually since I got married, and I was started work at a company called Quintiles, and I worked for Quintiles for about 14 and a half years. I started the company when we were very small. We were very founder-led back then. Now it's 52,000 people. So I had a really good ride of growing in a real growth engine company. And throughout that journey, what was really exciting for me is that I got to start out at the bottom of the totem pole. So I literally pushed paper files across buildings before electronic data capture existed. And I got to do all the sluggy, crappy work that you have to do to feel really excited about technology. And to really feel like, oh my gosh, I never want to do that again. This solves that problem. And so fast forward, I had an amazing opportunity to be a part of internal startups. And so about 8 years ago, I started in a small group of 12 people that became 7,000 people. It became a major business arm of the company, but it grew out of a startup idea we had. And then I did that one more time and then another time. But for the last 8 years, all focused on digital health. Had lots of different names because digital health wasn't sort of a cool word to use until most recently, but that's really in mobile health and digital health is what I've been doing for the last 8 to 10 years. And so about 4 months ago, I made the switch from intrapreneur in a big company to entrepreneur in my own company. And so I joined a company called Thread, and I'll give you a little snippets there. Threadresearch.com is the URL. But I kept running into Thread because I was working, one of the projects I worked on was ResearchKit with Apple. And so as I was working on ResearchKit, I kept running into this group, and I said, these guys are really passionate about the same stuff I'm passionate about. And I really wanted to come up with a model that we could provide a platform that would help people to do research mobily focused at a very disruptive price. Because I knew how to do everything functionality-wise. I've done projects that would blow your mind what data we've been able to interconnect. The challenge is they're too expensive. And so our mantra has been, how do we sort of really disrupt and be able to cut that price and make it repeatable without it feeling like just out of the box I click buttons and I pull up the 4 screens that everybody uses. And so we've really been on a journey to do that, and I'll kind of eke that out a little bit as we go. My role at Thread is Chief Product Officer, which means that I focus on our product, which is our platform, and how we service our customers. But I also manage our strategy and our marketing efforts as well. So let's just dive into this for a minute. So there's quite a few things that I want to cover today, and because that agenda is pretty packed. And so I'm going to try to hit some highlights of the things, but I want to start at this 30,000-foot view, and I want to start by giving you sort of a perspective on mobile health. Does anybody know what this is, by chance? That's what it is, 2005. What's really funny about this photo to me is this guy right here. You see his little flip phone? I got that in the photo. Do you guys see that? It's pretty awesome. So this is a very famous picture of Vatican 2005. Fast forward to just what you see when you go to the Vatican. And so what I want to start out by saying is that our industry, healthcare, clinical research, has a dynamic issue we're dealing with right now, and it's education. Because we're still living in a world where we think people aren't using mobile. And so I want to debunk all those myths for you right now and give you everything you need so you can start to move a business case forward, because this is the stuff you're going to run into, because I've run into it for the last 8 years. And even though the world's changed, people's mindsets haven't. So if you want to steal this photo, you should just show this to people, because this is 2013, guys. We've already moved way past this. But you guys know we're doing this. You're living your life in a filter called mobile. And it doesn't actually matter what economic state you're in, what socio-demographic you're in the United States focus. You actually are using mobile, and you're probably using a smartphone. So let's jump into sort of a little more principle around why mobile is not this thing in the future. So when you hear presentations about people saying the future is mobile, they are behind. The future of mobile is today. And let me tell you why that's the case. I'm just going to give you 2 of a slew of examples. One is my favorite one. Which is, anybody partake in Black Friday? None of you, okay, come on, Emma. Okay, so somebody partook in Black Friday. This is my favorite photo of this guy like getting crimped by doors. He's trying to like get a TV for like $50 off. That's pretty exciting. But this year, I don't know if you noticed, but the stats for mobile completely made the shift on Black Friday being sort of the result. We now have more people visiting mobile on Black Friday, the day that people go into stores to buy things on sale, was the highest. Mobile actually beat out in-store sales. It drove 55% of traffic. It did 36% of revenue. And if you look at mobile versus desktop, mobile now almost doubled desktop. So what I'm trying to lay a foundation for you is that our patients who are consumers are already mobile, and they just proved it to us all on Black Friday by doing something very simple that they do. And you guys know that besides like the Amazon app, most other apps that are out there suck really bad for buying things. So the joke in the data is actually that there were a lot of failed purchases in mobile, even though the size of the cart in value was pretty similar. We saw lots of fallout. In other words, desktop kept it better than mobile because people are still getting better at making mobile purchasing. So imagine if that experience was better, how much more mobile would have done. Let me give you one other sort of thing to think about, and this is just a fun topic of conversation because it's a horrible example and yet a very beautiful example of mobile health. So Snapchat, you guys know Snapchat, $19 billion. Have you guys seen this? $19 billion is their valuation. Do you realize that's bigger than most every single national and international hotel chain? Did you guys know that? So we're saying Snapchat is valued at more than major hotel chains. Now let's go to Uber. Everybody uses the Uber story. I'm going to use it because it's fun to use. $70 billion. We're saying that Uber's worth more than Ford and GM and other car companies that build the cars that the app helps you drive. Okay? So go with me in the story. And then we see MyFitnessPal, which is 4 guys in a garage. One of them I really liked, the other 3 I didn't really know. Built this thing in a garage, stunk it together, and said, hey, I think this is a really good idea. Those guys make basically their cut of $470 million from Under Armour like that. And they weren't the only ones. And so when I'm trying to stay in a very sort of egotistical way about mobile health is that the value of mobile health is not just what it's doing today, but what people perceive its future to be. And so I want you to keep that in mind. I also want you to take something from this presentation that you'll see throughout the day. One is that when you're building your mobile health experience or your app, don't think that you've got to be the next Snapchat. Don't think you've got to be the next Uber. And don't think you've got to be the next MyFitnessPal. If you set that up as your goal, you will fail automatically, and I can already tell you where to dump your money in a hole, okay? So keep that in mind that what you're trying to build is not the future of these. You're trying to build something that gets from your patient and supports them with value. We'll talk about that a little bit. So when it comes to healthcare, and again, my work has been in healthcare, but it's mostly been in pharmaceutical research. So pharmas, CROs, payers, and healthcare providers and academic research centers. These are the people that I've been working with for a long time. These are the people that Threads platform serves. And I'll tell you that mobile health is growing, and we're seeing really good movement, but it really needs your help. And let me tell you a little bit more about that. So first, mobile health. Let's start with a definition of mobile health and get a little bit academic here for a second. It's everything mobile. That's basically the definition of mobile health. And you can use that definition however you choose because everybody else in the known world is. But if you'd like to dive more into the definition of mobile health, a really great site is on this, and when you get the slides, you'll see it. Athena Health has an entire library of information about mobile health and connected health, and it's actually some of the best stuff I've seen. And I've written a bunch of this stuff. I like this better. So that URL is on this page. I'd highly recommend you go there to look at more in-depth definition. So let's talk about sort of this research arm as we set up sort of where mobile health is going. So let's start with 2010. So we're only looking back about 6 years. This is how many registered studies on clinicaltrials.gov, so registered studies that had a mobile health component initiated, 42. I was doing 5 of these, and we thought it was awesome because we were doing stuff that really we didn't know how to do, and there was no book written on it. And I spent the next 3 years of my life writing all the books for AHRQ and the government on how to do this stuff because we learned by making a bunch of successful mistakes, basically. So if you fast forward from 2010 to 2015, you see this 8x jump, which is pretty exciting. I mean, guys, this is where we're seeing the growth. And as you're hearing about mobile health studies, what you're hearing is a part of this change. But I want to help you understand that a lot of people come out about mobile health and say, 328, 8x change. Isn't that amazing? And I would tell you that the opportunity is still a little bit in front of us because that's the baseline. That's the denominator we're working off of. That's how many studies were registered in clinicaltrials.gov. And so what we're telling you is that it's actually less than 1% of studies, research studies, had a mobile health component to it. So I'm trying to lay out that there's some great work happening. It's not early for mobile, but it's early for healthcare and research. And as many sort of metrics and data points as you see, 90%, 6% of physicians are using mobile health. I would challenge that number because I'm in with those physicians and clinics all the time, and I would tell you, I don't see that at all. And what I would tell you is that this metric is online and in clinicaltrials.gov that shows that we have a long way to go and a lot of room to work within research. So does this all make sense so far, just as we sort of set this up? Again, just to set the stage for you. Let's talk a little bit about, so if we've got this, this is what the market is. This is sort of the opportunity we have. Let me tell you the biggest concern I have. And when people talk to me today about mobile health and doing studies, I would tell you this is my #1 concern. It's not about what the technology can and can't do. It's not actually about adoption and changing people's mindsets to do this work. My biggest concern is that patient expectations are getting really high in mobile. And the reason is an example, is these guys. So I don't know how many of you guys have kids. Anybody ever been to Disney World recently? The last one. All right, so let me tell you a little story. So I have 3 kids, I have 9, 7, and 3, and half my salary goes to these guys in some form or fashion, whether it's, Star Wars, princesses, it doesn't matter. And when this Magic Band came out, which I'll tell you a little bit about, this is sort of this wearable that Disney has. When it came out, I got this opportunity to pilot it. And because I'm a nerd and I have a lot of friends in digital health, I was like, I'm there. We took a trip, piloted this with my kids. So picture my little kids, like my little blonde girl, walking around with her little Magic Band like the size of her forearm because it was a prototype. And it was super cute. And we were trying out this method. And as we were trying out this wearable, it really hit me really hard that I realized that, oh no, Disney just cracked the digital health nut. That's really what I realized. And it took me the whole end of the trip to figure it out. So let me give you the reason why I tell you. Is because the wearable wasn't just a wearable to just be a wearable and to track steps. The wearable was unlocking things like how to get into my room. So it's a room key. It was my photo pass. It means if someone took a photo, it showed up in my account. And it used to be 50 seconds, now it's a second. Literally, dude takes photo, upload, it's on my phone, okay? It was a way to get my fast pass, so like my quick ride access. It was a way for me to get my admission in the park. It was my money, right? Like my kids go up and scan stuff, I hit a PIN code and spend like $1,000, right? Like instantly on a wearable. But the cool thing about this My Disney experience is that it also had a web experience and a mobile experience, and all 3 of them differed, but all 3 of them were getting to one key point. One is they were trying to service me as a customer first, and they were going to collect data from me second, so that they could actually improve the experience they were giving to me in the front end. And so if you look at this experience is not about collecting data, which this is, I would argue, the biggest health data collection tool ever invented right now. What I would tell you, though, is the method they used to have an omnichannel experience that collects data in multiple ways that uses the sources at the best of their ability is where I think mobile health is going. And so I want to dive into that a little bit, but I would tell you when you, when you think about, for audio. Yeah, sure, thanks. When you think about these patient experiences, right? These are getting so good. So our expectations are getting really high. So when we come out with a really crappy healthcare app, and our patients go, oh, cool, and they download it because they think it's nice that we're giving them an app, and they see that it doesn't look like this, or Snapchat, or Facebook, do you guys know what they do with it? They delete it. They dump it. So I want to be very clear that part of our goal, part of our mission is not just building the tool that collects data really well. Part of the things that we're building in mobile health are around how can we collect data from people by giving to them value first, collecting data second, and making that experience super frictionless. We'll walk through that a little bit.
And for that one, I think I remember you mentioned this before. It was something like 25 companies that were part of it. It was something like $1 billion effort to put that together.
Yeah, it's right. It was Brian, you're right. It was $1 billion investment is the estimate. I think it's 46 interoperable systems that work in the background to make this happen. But here's the deal, guys. Nobody at Disney, when my 2-year-old's using this, they have no idea there's 46 systems working because it's super simple. And this thing, again, is collecting data like you would not believe and actually helping to move people in the park to where you want to based on traffic. They're doing population health in this. We just don't think about it that way because we think about the consumer experience. And so I tell you that, again, this is the things we're starting to get compared to. So be prepared for that. So let's get into this. So what do I need to know to develop an app? I think that's really the sort of premise. So I hope that kind of gives you, again, really fast. I've done like 3-hour seminars to tell you about mobile health. I try to do it in basically 15 minutes. So hopefully that gives you what you need as an overview. So let's move into this. What do you need to know? So I'm going to start telling you another story. So I was working in one of these local startup offices. You know, like you guys know what I'm talking about, like Frontier, American Underground, Raleigh HQ. And these are, if you're like a science guy and you walk in these offices, you guys know you need to be a little bit like hipster scientific. You need to be kind of cool to be in this place because these places are super nice. You know, you got all the glass windows, glass walls everywhere. These like birch wood Starbucks tables that we're all sitting around and working. And so trying to give you this mental picture of I'm in this thing and today it's full. There's like 320 people in this building. And it's all startup people working and talking in their headphones and cranking away. And I'm sort of in the, like off to the right-hand side of this room, and I'm having this call with this customer, and I'm trying to convince them why what they're trying to do in desktop is a really terrible idea and why they should do it in mobile. And I had been working on this customer for basically 3 months of like, guys, I'm going to do it, whether if I fly down there and make you do it, like you need to do this. It's really important. And as I'm having this conversation, I'm at that one call where they kind of say, okay, John, we're good. We believe you now. Let's go. Let's do it. And so you guys know you've had this call, right? So like I get that call and I'm like, you know, you can't like tell them on the phone that you're like physically excited, but I'm physically excited because I'm like, I just scored. I convinced them after all this work to get over that hurdle in their head to do this work. So you got to realize, like for a guy like me that works in a startup, when you close a deal like that, you basically do happy dances everywhere. I mean, that's just how it works because cash is cash, just to let you know. And so I'm hearing like Eye of the Tiger playing in the background. I've got my backpack on, like I'm pretty stoked. And as I get up to sort of slow walk out the building, I start walking and really thinking about sort of the change that we're able to make. And as I'm looking forward, I look down the hallway and I kind of just like through that door, I look through the hallway and I see my next meeting down there and the guy sitting down and I say, I'm going to walk to that meeting. As I'm walking down that thing, I ran into this. You guys know what this is? It's called a glass wall. In case you're curious, it's a glass wall. And I'm not joking. I ran into it. I fell over. 3 people came to my rescue out of like 300, which is a little concerning. And I really, as I'm on the ground, I'm thinking like I'm going to have to get medvaced out of this place. And I'm not joking when I tell you that I was bruised in my eye and my nose. My son, when I got home, my son said, Dad, did someone beat you up at work today? And I was like, no, they didn't. But yeah. And so what I want to kind of give you a premise for as we move in the next part of the discussion is that I think this is a good surrogate for how you guys are thinking about your work in mobile health. And so go with me for a second. So when you see a goal, and you're all in here because you're trying to build something, you're innovators, you're knowing how to do something, you can see what the end result looks like in your head in some form or fashion, right? Because you're an innovator. You can design that thing. Doesn't mean you have it perfect, but you have a general idea of where it's going. And you can see the end of that tunnel. And sort of that office at the end of the space. But what I would tell you is that if you're not careful, you're going to run into a bunch of walls that you're not seeing. Because you're so focused on the end result that you're going to miss these interim steps you really need to go to get people to see with you what the goal looks like. Meaning that, you work with these people. These people, when you come and you say, I want to do this mobile health app, they go, that won't work. Here's the 50 reasons why. There's a regulatory ethics issue with that. You're going to get those walls in front of you. But honestly, we're all the type of people that that's all done in our mind. And so we look past it and look towards the goal. And if you do that, you're actually going to run into some pretty big walls. And so I want to give you a couple actionable steps, some things that I would encourage you to follow to make sure that before you think about mobile app development, you actually think about how you plan it and design it. Because I will tell you that I've done consulting with pharma, payers, healthcare, academic organizations, and I've installed a lot of these platforms in those institutions. And these problems happen to everybody, from the most innovative institutions I've worked with to the smallest companies. These consistently come up. So let's tackle these real quick. So one is you have got to influence your key stakeholders. So when you're thinking about something you want to do in mobile or digital health, you need to know exactly whose mind you're trying to change, or exactly who you need to convince to get your funding, to get your project to go forward, or to help support where you're going. And I'm going to tell you really quickly that there's two types of people I'm going to tell you to avoid. The first person I want you to avoid, the first group, is people that do this. So in our population in the US, there's about 8 million people that have done this, and you may be surprised to know what it is. It's actually have used an Uber. Do you guys know that only 8 million unique people have used Uber before? So think about all the presentations, all the news articles, all the topics you've heard about Uberization of your bathroom or whatever else we can Uberize. And the reality is lots of people talk, very few people are doing. But these are the people that you're attracted to probably if you're in mobile or digital health, because these are those innovators. These are the guys that can talk and show you PowerPoint slides and get real excited about something. The reality is they're already in your court, move on. Don't spend your time hanging out with those people. Those are not the people we need to convince. On the other spectrum, you guys have heard in Crossing the Chasm, sort of this group of laggers. These are people you're never going to convince. There are 2 million people using this service today, and I guarantee you will not guess what these 2 million people are, so I'm just going to tell you. This metric was in December of last year, and it still holds true today. But this is how many people paid for AOL dial-up in the US. And I get this question all the time. I actually had a researcher from Merck, actually, and he called me out and he said, hey, some people have to use AOL dial-up. And I said, actually, no, this is actually scraped. So the people who only have dial-up in a mountainous area are not even in this data. This is people who choose to use AOL dial-up and pay for it. Okay? So I want to be clear that if you're getting the idea here that we naturally have this tendency to go gravitate towards these people that think like us and that want to be innovative, or gravitate towards these people that were like, I'm going to convince Brian if it kills me to get on board. And I'm telling you that 99% of people that are in this middle road, these are the people you need to focus on to get on your team, to understand your project, to be a part of what you're doing, and to really get that vision. And so I would tell you over and over again, those two groups are the groups you should avoid. Next is a scalable business case. Have you guys ever seen a business case for mobile health before? Anybody ever seen a business case? Did you have to write a business case for your project that you're thinking about?
Oh no, it's research. So
A grant.
no.
You didn't write a grant? So
Well,
you did. So to get the money, what do you have to write to get the money?
It's my startup funds. So I haven't written anything.
You're lucky. That's awesome. Congratulations. So everybody else has to do a business case, whether that's in some form or fashion. And if you don't have a business case example, this is the best one to start with, okay? This is not the best one. It is the best one to start with. This is a lean startup model. If you guys haven't read Lean Startup, it's one of the best books to read. Just put your mobile health brain on when you think about it. And these are some of the questions you need to think about. So what I would tell you that's different is when most people come and do mobile health, they think about like, okay, what data do I want to collect and how can I make it easier to collect from people I'm seeing? And I would tell you that if that's the way you start your business case, you're done already. The way you need to think is if I were going to build an app that people wanted to use and would pay me for it if I could charge them for it, what would it look like? You need to build your app like you're building a startup business. So the fact that you have the startup funds is good because you're thinking about this already is how do I multiply this? How do I get network effect out of it? And I would tell you that building a business case like a startup will go a long way for making sure you've thought through questions that you typically won't think through when you're just trying to spin up an app in a hospital system.
And I think that I think a lot of people in the academic center have not maybe heard of read The Lean Startup as a book. He goes through great pains to say that a startup is any group of people doing something that hasn't been done before, basically, and in which it definitely includes academic, nonprofit, other things. So it is I would say, a profitable way to go. Although I do sometimes in my head still think about these categories and think, how exactly does that translate to, an IH grant? I'm not exactly sure.
Yeah, it does. I actually helped 2 institutions do an AHRQ grant and another grant using this principle. Yeah. And what's really interesting is, because I was just at Capitol Hill and IOM speaking on this topic, and one thing that's really interesting to me is when you hear regulators come back, and when you hear other people come back, they say, actually, the problem we have with a lot of the applications is they're not thinking about the long-tail scalability of this. Because remember, originally we were building mobile health, we were building it to try out the idea. Now we're building in mobile health to make things cheaper over time. It's a longitudinal discussion. And so what people are looking for is not just a business case for what I'm going to do, but a business case for how am I going to sustain something. Everybody track on me, okay? Trying to hit some numbers. Okay. Omnichannel experience. Anybody know what omnichannel experience is or means? Anybody want to tell me what it means, just for fun?
It was what you had with Disney.
That's right. That's a good example. Give me a little more color to it, Ava. What else is part of omnichannel?
It's basically all the different communications that come to you in a day or in a week, the TV and books and online information, everything. It's messaging, and if it's a good messenger, they're coordinating all those different experiences in the way that you're receiving.
That's right. Let me add one more layer for you too, and I sort of made the definition a little specific to healthcare and research. But omnichannel is when you're using the experience for its best attributes, which means think about how when you fill out a document, if I said, hey, could you read and fill out this 27-page Adobe PDF document on your mobile phone, you would literally look at me and say, I'm done, right? That's a good, easy example of something that should be on a web portal. But if I said, hey, I want to give you directions to something, please don't put that in my web portal, because I'm not carrying around my mobile web on my phone. I want something that works with my GPS or my Google Maps, right? So you're thinking about the functionality or what you're giving to a person, a patient, a consumer, and you're thinking about that by using its best ability. And so what I would tell you is when you think about omnichannel, it will make sure that you don't force fit stuff into your mobile experience that doesn't work good in a mobile experience. And it makes sure that you put stuff in web that works good in web, but you're not trying to make your web mobile. One other thing when you think about omnichannel, and this is the biggest failure that I'll tell you I've seen in a lot of apps, kind of a metric that you should know about that we don't really talk about or publicize it very much. But when you look at health apps that are in the App Store, you'll hear these numbers like there's 325,000 health apps in the App Store today. What you don't hear about is the number of apps that are not used and that are pulled from the App Store because the company shut down and closed them. That's not a metric that Apple reports on. If they did report on it, and I've seen some of those metrics, you would be shocked to know that most of these apps are just not that great. And I would tell you that the reason they're not great is this. So I wanted to give you this. This is a tool that we use. It's an engagement predictor. But the idea is whenever you're building something, you're thinking about friction and motivation. And so whenever you're building something in mobile, you need to make sure that when you think about what you're going to take from a patient, you're equally giving back as much value. And you also need to make sure that you're not overburdening them. So in your usability testing in an app, if you need to know when you're deploying something how many minutes it takes for an average person to complete it, if you're in, like I'm doing something that's actually Empower, which is Parkinson's, we know that some of the things the caregiver is doing can take longer, but some of the things that the actual patient is doing in mobile need to be a lot shorter because it's very complex and hard for them to do. And so you have to really think about your patient constituent, the condition they're in, and then these friction and motivational factors.
When you're thinking omnichannel, I saw the last one on the list was on-site. Have you done much that has that like a paper component at some point?
Yeah, not paper, mostly like where I send people to a clinic or to a lab. So there's some sort of extraneous thing that needs to happen. When you think about virtual clinical trials or virtual research, that's where instead of the research starting at the clinic, I'm doing it virtually with one central primary investigator, and we're enrolling lots of people across the U.S. And then if we say we need a lab draw, if it's 23andMe or genomic lab, I send them a kit home, match the data. But if I need to send them like Quest, because it's a more complex lab, I need to be able to send them to Quest and understand in the experience, is that frictionless or is that like a lot of work for them to do? Does that make sense? And so you kind of have to, as you get into sort of the hubs and spokes around mobile health, you have to think about those different avenues. And then one more time is when you think about this ecosystem, you know, a lot of people think about putting up their app. They don't think about how are people going to get it, where's it going to be placed. So they don't think about like the recruitment efforts that go into an app. And what I can tell you is that they're really complex and something you really need to think about, because just building an app and putting it out there, you guys know this, it's building a field and no one's going to come to it. You have to actually make sure that you know how to direct people and put that app in a place where people want to consume it. So what I would tell you is that whenever you're building a mobile experience and you're thinking about omnichannel, just like Ava mentioned, you have to think about where's my social presence? What's my app store presence look like? Very important if you want to get downloads, by the way. What's my, am I putting this with any local organization affiliates? Is it going to be on a on an advocacy group, wiki, or a travel page. So thinking about where the placement of this download is and how quick and easy that is really important. All right, this fourth point is around iterative design. So we could spend like hours talking about iterative design. I want to give you sort of the top line stuff you need to know. But how many of you are already tired of hearing about design thinking? Like the word design thinking? You guys heard that already? Okay, please tell me you've heard it. So design thinking is quickly becoming a buzzword. And I would tell you that there are some people doing really amazing work in design thinking. There are some other people that are like scribbling stuff on sticky notes, sticking it on a wall, and be like, "I design thinked," right? And so what I would tell you is, let me give you some of the principles of design thinking to make sure that you slow down and you walk through them. These are the most important attributes to getting your app right. The first thing I want to say, you guys know what this is? It's an air freshener, right? Kind of reminds me of like, when you put it in your car, the first week it smells really good. And then like the second week, you're like, is that tree even working? You know what I'm saying? It's like, it's gone. By the time you get to iterative design, this is what your team is doing. They're starting to not smell like anything fresh anymore. Design thinking is really hard work, and it's not fun. And I think a lot of people think it's cool, it's like sexy work, or it's like, oh, design thinking, cool. It's hard work. Iterative design is a slugfest. I've been in some apps where we have beat that app's design up 42 times. And because we wanted to make it better, we got usability testing, we got feedback on it, we made it better. Then we got feedback and we went, oh, we didn't do that one right, let's get it right. So I'm telling you that this is the part that really separates the doers from the talkers. And so think about design thinking in that way. So here's what we do for design thinking, and I really like it. I've done about, our company's done about 45 of these. I've done the last 10. And it doesn't actually matter who the customer is. When we walk through this process, it's been amazing to me to just see how people respond to it. But I will tell you that design thinking is, as much as you want to be like loosey-goosey and like, let's just flow the ideas. If you do not have a construct and a methodology to get there, you will never get past like the first or second step. As a matter of fact, you'll just sit in ideation land all day long, and people will just be like, oh, what if it made McDonald's burgers pop out the bottom of it? I mean, like, people will seriously just think about stuff that makes no relevance. And so when you think about how you get through design thinking, what we're doing is called Context Roadmap Workshop. And so this is our process for taking design thinking with a little bit of a step back. And so let me give you some of the elements of it, because I think some of these might help or be something you want to think about. Now, one is our goal around a design thinking workshop is actually to take digital out of it. So if you're doing a design thinking workshop, I would implore you to take digital out of your workshop. And that sounds really funny for the digital health guy to say, but I would tell you that when people get on websites and start drawing stuff, they start getting into form factor and like, well, that box isn't as far left as I want it, and you are losing hours as you speak. So I would highly encourage you, get out of digital, make people close their computers, and write this stuff on whiteboards, get it on walls where the design doesn't matter, the content matters. What we do when we walk people through this process is we start with a business context. So we say, why are you actually trying to deliver this app? And who cares? And who's going to use it? And what are the features that are going to provide value? What data are we trying to collect? So walking through the high-level principles of scope, which is why do this at all? Once you get to that and you sort of lay that out, then you start ideating. A lot of people just go, hey, I want to create something, let's start ideating. Don't do that. Start with your business context. After you ideate with a very set period of time, we have an egg timer that literally goes on a wall. And I've been like, in front of like 35 people in a room, egg timer goes off, you cut it, it's done. Because you can continue to ideate. But you guys know how to do ideations where you're really thinking through and brainstorming around how do I make this business context come to life. After we ideation though, then we go to the purpose and goals. And on purpose, we go this way. Because what we do is we're telling people what are we trying to achieve. We let them ideate about it, and then we're bringing them back to what am I trying to achieve. So that we make sure that everything we just ideated about actually has a purpose and a goal. Make sense? So think about, you're kind of going back and forth in your design process. Then we talk about, okay, so once we have that purpose and goals, we kind of know what we're trying to do. What's the approach that we're going to take? What does that platform need to look like? What are the functionality that are part of it? And as you guys can sense, we go through the rest of these steps, but at a high level, critical behaviors is who is on the team, how are they going to act, who's the person that makes the decisions. Can I tell you that when you put this kind of thing in design thinking and you put it into your workshop or your process, what you will find is that the people that need to make the decision will be called out and the team will back them up, which means that when you're all thinking that you all have a brilliant idea, but that person's the decision maker, you're calling out what the critical behavior is for the team and who the ultimate decision maker is. So who gets to make the final call at the end of the day. I would tell you that a lot of people don't do this. They sort of think about very community, very group think, let's put it together and let's go. You've got to get to where we know exactly who's responsible for what, who's going to sign off on what. And then the rest of these are pretty clear. The one I like the best, though, is one of my COO, who I work with all the time, talks about doneness. And doneness is a technical term. It's not. It's just completely freaking made up. Doneness. Doneness is, what does this thing actually look like when it's complete? And what I would tell you is most design thinking never actually gets to step 7 and 8. And I'm telling you guys, like I've seen it over and over again with some of the top firms in the world, they never get to 7 and 8. They get to like, and here's our risk. All right, well, it's been a great meeting, and we'll see you guys later. You've got to get to defining what done looks like. What does this thing look like in its first iteration, in its first MVP? And then what are we going to do tomorrow and in what order? If you don't have that, your design thinking is short-lived. You guys track with me? Does that make sense? Oh no, I must have a bunch of builds in here. So when you think about this process, these are a bunch of really bad visuals that aren't coming through, right? That's okay. When you think about this process, once you get to design thinking and you've sort of gone through that workshop or that perspective, the thing you also need to do is you need to lay out how this thing works step by step. A lot of folks do not do this in their app. And I would tell you that the best apps, the best firms, the best groups in the world do this and are really good at it and at doing it fast. Because what you're trying to do is you're trying to design out each and every little step that someone takes. If you don't do that, what you will build is an app that misses out on a key step, and the second you go to do usability testing, the patient will say, well, I didn't know what to do next. And it doesn't matter how great your app is, if that step is not there, you will miss out on the end goal. So remember that there are a number of deliverables that are required out of design thinking. It's not just about going to a meeting, taking some photos. It's actually about getting into place. What are the screens that make this up? And I would tell you one.
It seems to come up again and again and again is that in healthcare people are thinking like, oh, I just want something that the end user is going to be happy with. But there's so many other people in the process. There's the patient, but then there's the provider, and then there's the administrator who pays the bills, or maybe the payer pays the bills. So,
yeah, that's right.
How do you sort of inform people about that process, to get to that point?
Yeah. So typically do that in the business case. And I think that's actually a failure in not design thinking, it's a failure in business case. Mm-hmm. So business case would say, if I'm going to build a business, these are all the stakeholders. And you see that, it's actually in the chart. Who are the stakeholders? Who are the people I'm trying to serve? I have a primary, the patient may be my primary, but here's all the other people I got to make sure that I keep happy. Here's all the people that may need to see a portion or a piece of that data. You're absolutely right, but that's a business case issue. Is I think a lot of people just, again, focus on not the business model, they focus on the app. And if they don't step back and do that, by the time they get to design thinking, you're absolutely right. They spend all this time on the app and no thinking about how it actually services everybody else. Mm-hmm. Yeah, please.
I have a question about the testing of the mobile app. So when you design this and you send the app to whoever involved, maybe the patients, maybe the caregiver, and now the app is out of your control. And do you also send them the tasks you want them to perform, or it's up to them? Well, however.
Great question. No, you're spot on. We typically, so if you're in a clickable prototype is very task-based. Mm-hmm. So it actually says, here's the 5 things you can do. And so what you do is called a user story. You give them the sim with a user story, and you say, hey, can you do these 5 things for me? And if you don't do that, you're absolutely right. You will. There's a lot more there, but that's at a basic level. Giving them the user story is really important.
And you have the results to compare.
Correct. The thing that's interesting is remember when we're doing usability testing, make sure a lot of people do this, but some don't. We have to do it to ourselves as well. So let me give you one of the principles. So my team, and my former employer, my team had this poster on their wall, and we sort of made this a part of our sort of 5 tenets that we followed, and it was think like the patient, not about the patient. And so when we thought about our design thinking, our principle was we didn't want to send them something and say, okay, you fill this out and let me know how you feel. We actually usability tested ourselves. We said, okay, I'm this patient. This is the condition I have. This is the challenges I have. I'm going to test that as if I'm the patient. And so timing things that, just very simple things. A lot of people don't do. They kind of build it and they go, it's awesome, send it out and let them feedback it to us. You know, make sure you take time and you test it yourself as well.
After that means that you do like a classic usability testing of any information system. So
Correct. Just like UATs. I mean, it's just UAT with fancier words. You know, that's basically what it is. Yeah.
So I'm really curious about this because it would seem to me that sometimes you might miss out or misguess how important something is if you start in there. That if you started with consumers earlier, or whoever the stakeholders are earlier, and got them to rank, or got them, this is important, like, you know, what are the top 3 things you're looking for before you then come back and say, okay, here's now the click-through.
Sure. Yeah, so let me answer that this way. So 6 years ago when I was building mobile apps, that was what we did all the time. Now I've worked in 100 conditions. We know in principle that these are form factors that works, and we do that for new features or new functionalities we want to try out. So what we do is in the sim, we say, like, here's the standard, here's the new thing we want to get feedback on.
Okay.
And remember, a sim, we're talking about weeks. So don't think it's like we're taking 3 months to build something and then do it. We're actually doing that really early. My team burned out a sim for a fully functional app in a week yesterday, and we do them about 50 of them a year. So it's not hard, it's not expensive to do, but you're right, you want to spend time on, like, here's the standard stuff. We still want them to test it, but this is like the innovative thing I want to try. And when you're doing sims as well, what you have to realize is that there's some things that actually you can't test great in a sim. So like there's a number of, we'll talk about later in research kits, a number of active tasks that we built that are sort of these, they're active surveys that you take a part of. So in other words, like stage or gait and balance. So instead of like doing the 25-foot walking test with a nurse sitting down and scoring you as you walk, you pull out your app, it says, hey, John, are you ready to take your walking test? If you said no, it'd come back to you later. If you said yes, it would say, great, can you see about 20 steps in front of you? And you go, yes. And it goes, great, put me in your pocket, I'll talk you through the rest. You put it in the pocket, Siri kicks on, it says, okay, John, start walking. And Siri becomes your personal assistant. Siri becomes your nurse to help you walk through that flow, right? When you're building those, you can't sim that. So we did it, launched it as an MVP in an app, tested it with 25 patients in this very particular condition, and got feedback from them before it went out to the bigger group. So you're absolutely right that there's some things you're trying to build that are really complex that actually need to be in a live environment as well. Makes sense?
yeah, no, sorry.
Fire away. No, don't be sorry. It's for you guys. Fire away.
For the mobile app, like the testing, do you need to apply for any kind of IRB because you involve patient involvement and feedback and testing?
Yeah, great question. So regs on for testing you don't, because you're not enrolling somebody into a study. The only caveat is if you're submitting for a 510K, which is a 510K or a 510B, if you're submitting for anything around a medical device certification or like a CE mark, there are certain steps you have to follow where you do have to get IRB or EC input, especially if you're in Euro 5, okay, or Latin America. But in the US, if you're just doing a consumer-based app, something that's not going to be registered as a medical device as its intent, you can absolutely test that without IRB approval. And it's happening all the time. When you get for that to be a study, when you get, like, if I were going to launch the real app and start to collect data on, remember those 20 people I said I was collecting data on? That we submit for IRB, but you actually submit it for a waiver. So you say, here's what I'm collecting, here's what I'm going to do. The IRB makes the call on if that provides different forms of risk to the patient. Traditionally it doesn't, because you're just testing the form factor of an app, and they give you a waiver. It costs you like between $200 and $900 depending on who you're working with. But that waiver certifies that you went through that regulatory process before you tested. Let's crank through sort of the rest of this. So I want to talk about, so the last pieces on that agenda was about how do you think about functionality, how do you think about APIs, how do you think about partnering with people? You guys ready? Are you okay? Like, I feel bad because I just like preach at you for 45 minutes. This is usually when people are like, I'm done, I'm out. So I'm going to keep going. Hang with me. Ask me questions. Stay engaged. All right. So let me tell you how we see the world. This is how Thread sees the world. This is what we've been doing. This is what we're doing today. We're thinking about this ecosystem, about how do you put together functionality and APIs as one API-based platform. meaning that what we have done is, because we helped launch 4 of the first 8 research kit studies, we're launching the next wave of research kit, and we've launched the next wave of care kit as well that's coming out in quarter 1 and quarter 2. And a lot of those studies, what we've learned from them is that Health Kit is just a data repository on your iPhone. Research Kit and Care Kit is open source SDKs that you can contribute to in GitHub. That these SDKs are great for making research apps really fast. What I will tell you is that they require a lot of customization from pretty complex programming. And so the net is that even the initial research kit apps that came out, about 20% of what you needed for an app you could get out of a research kit. The other 80% you had to pay for programming. So the average app in the originals and sort of the original research kit work that was coming out was $250 to $300 to start. So the intent of research kit was to build things that academic researchers and other researchers could do on cheap, right? That we could afford. The reality is that it, just like anything as an MVP, it started out where it's too expensive. And people are sort of saying, well, great, I want to do this. And we were like, well, research kit doesn't, it does this, right? And so what we learned in sort of building this work is that we had to build a platform to do a couple things. One is to build functionalities and APIs that are never going to exist in GitHub. They're never going to be part of the open source. We also had to build functionality that and compliance that made this research kit and care kit to work in the complex environments we work in. In other words, I can spin up a research kit app and do a local site study. To do something with multi-drugs, RCT, or observation studies globally requires a lot more compliance, regulatory rigor, and functionality that's required to be segregated. So we built a platform that basically did that. The intent of what we're doing, just to give you an idea, is that I'm trying to deliver apps in Research Kit primarily that then convert to Android and Research Stack for super cheap, like 1/6 of the cost. So today we're delivering apps for studies at about 1/6 of the cost of what the market is. And we're going in and installing these API-based platforms into hospital systems and pharma companies. And so they install it, and then they can actually drop down and sort of build apps they want for, again, like you're talking like $80K an app. So I don't know what your kind of budget is. We can talk about it after. Think about it. Okay, so you're gonna get you're gonna get an okay app for less than that. But what I'm trying to say is, principle first is when you think about these platforms, remember there's a lot of people coming in the market that are sort of working with these and building out their own things. And this is really new. Like, I'm doing something that's really innovative. Guys, I bought, fired, and hired everybody in this space for the last 7 years. I'm building what doesn't exist because I know what the market needs. And even in doing that, it's a challenge. But what I would tell you is that when you think about these APIs, when you think about connectivity, I would tell you to go to open source SDKs first. I would tell you to look at, if you're trying to do research, go to Research Kit. And also go to Research Stack, which is the Android conversion tool. Learn about those tools, apple.com/researchkit. Go to those tools, learn about them. You'll see a bunch of our work, but you also see a bunch of videos and things that will sort of inform you. Because these today are actually the most economical way to build an app and build a study with most of the rigor you need to get something out the door. When you think about APIs, though, what I would tell you, and I'll get to you in 1 second, right? When you get to APIs, what you need to realize is that APIs are all about what external functionality I need to bring in. So let me give you a couple examples. So in Research Kit today, there's now a connection for 23andMe genomic labs. Okay, now you got to spin it up, you got to connect it. There's a lot of work to do, and it ain't cheap to put it in. But if you said, I don't want to use 23andMe, I want to use this other genomic lab, or I want to connect to Quest Labs, what I would tell you is that you're going to have to custom code that, build an API that matches to that, and you're going to spend 3 times as much as your whole app on doing that. So what you need to look for is platforms and individuals that are sort of parsing and packaging up these APIs. And there's people like us and Validic and other companies that are doing this. Because what it's doing is it's making the end-to-end cheaper. It's bucketing up what you need so that you can then put that into your app or into your study design. That's actually how the market is moving to make itself cheaper. And it's actually just like financial institutions and banking have just recently gone through that. We're doing kind of the same thing. Does that make sense so far, just platform high level? Okay, so now I want to give you, just with about 10 minutes left, I want to give you guys a couple nuggets that are, so we talked really high level about mobile health. We sort of talked about design thinking and some of these principles that you need to do when you're going to build a mobile health experience. This third level is I want to give you like some really nuts and bolts, really granular stuff so that you kind of understand what's in Research Kit and what can and can't be done today. Because I actually think as you're starting to think about building these things, you're really going to want to start to learn about them. So let me walk you through a couple of the modules that are in Research Kit to start. One is, in my opinion, the most innovative module there is. It's called Active Tasks. Any of you guys heard this? Have any of you guys been given like a Research Kit spiel? Brian, you have. Okay. Are you guys okay if I keep going through this and go walk through? Okay. So when you think about active tasks are just like I described, like that walking test, but they're really simple ways to actively collect data from patients or people, but by making it very simple to do and not a survey, it's collecting things in more of a sort of a more free-form factor. And what you need to know about these active tasks is there's about 20 or so in the library today. I can tell you personally, I think we're putting a slew of other ones back into open source over the next year because there's some really novel ones coming out right now. When you think about these active tasks, though, this is how they work. It's an instructional step. So it says like, hey, patient, I'm going to do tapping speed. I'm just going to give you this one example. And then you say, okay, here's what else you need to do. And then the patient clicks, and you say, great, now do the action. And then you complete the action, it says, great, you completed it. Can I give you guys another scenario just to make sure it resonates in your brain? I want a mortgage, and I go to lendingtree.com. Hey, do you want to get a mortgage? Yeah, I'm interested in one. Are you sure? Here are the rates. And you click through and you go, yes. And then it says, okay, pick the rate you want, and we'll answer these questions. And then you say, great, you click OK, and it goes, great, you're complete, we've just submitted it. Make sense? So a very simple process that consumers actually already follow. We're just taking healthcare principles and making them in that workflow. I have in the slides, just in case, because I know we're going to send some afterwards, I put a list of all the active tasks that were in the repository for you, just in case you're curious to know what's out there. These are actually kind of hard to find. There's not a lot of websites that are sort of summarizing this, but the net is that there are a lot of them. Let me give you a little more principle to this. There are a number of active tasks that are doing things like fitness, and so I want to give you some perspective on this. Remember that the greatest wearable we have today is this. Okay, I've worked with most consumer wearables, most medical devices. I put them on patients in 21 countries. I'm trying to tell you this is still the most powerful wearable there is, because this is the device that people can't leave. This is the device that people don't really need to charge as often, and they will die if they don't charge it for some reason. Like, this is the thing that people attach to. So think about this as being sort of that in that omnichannel, this is sort of the port of call for that experience. And know that your phone, whether you're iPhone or Android, has a number of inherent sensors on it. That your iPhone actually has some more accurate accelerometers and pedometers than all the classic wearables that we're spending $200 and $300 for today. And so what you need to know is that when you are doing these active tasks, you're actually turning on different sensors in your phone and allowing your phone to collect contextual data that meets up to a goal and provides an outcome or a result. I got a bunch more slides in here that I'm going to kick through just for time. This is the gain and balance. Again, I'll leave these on deck for you guys to see. One of the things I think is pretty cool is now what you're starting to see is, so we've done a bunch of work with EpiWatch. So again, not the, still an expensive device. I'm not saying it's the one that we're gonna do for everybody in third world countries or even in the US. But there's been some specific instances where the EpiWatch has had some high frequency sensors that are actually better than what's out there that we've needed to understand some patient populations. And so one of the studies that there's a case study in here for later that we did is with Johns Hopkins. It's called EpiWatch. So if you've ever heard of EpiWatch, that's it's a seizure tool. So the patients enroll in a longitudinal observation study in mobile. They download an app on their Apple Watch. I have it, but I won't sort of walk you through it. And the net is if I'm an epileptic patient, I meet the criteria of this study. When I get ready to have my aura, that this is going to happen to me, I can do a one click on my watch. It actually shows up as a little dial in the corner, and it will activate the high frequency sensors in the watch and on the phone that would kill your battery if you left them on all the time. It just ignites those. And then when you have that seizure, it is collecting all that data from that seizure. Phone, geolocation, the whole 9 yards, all in one space. When you're done, you click I'm done. It wraps up the case and it launches a quick little diary on the watch. So as a patient, you just had a seizure, you need to sit down. You're not going to take out your phone and answer a bunch of questions. You're going to say, I'm already here, yes, no, right? So just that simple interaction is collecting seizure data has never been collected before, ever. And if you think about how seizure testing is being done, I have a family member who's gone through a lot of this, and I sat in that room, you go in a room, you put on a helmet, it's about $20,000-ish for an evaluation, and they basically try to get you to seize in the room so that they can study you, and like almost 10 to 1, it never happens. And so what we're trying to do in research is, in this experience, patients are actually getting content education materials about how to deal with their epilepsy, but when they have an event, they're collecting data. It's actually helping us to predictively start to find out if someone is having a seizure. So imagine if in the future that EpiWatch app is not waiting for the aura to happen, it's telling the patient you're getting ready to have a seizure. Pull over. Make sense? That's the future of digital health, guys. Like, that's just one example of many about where this is going. So anyways, I've got one other thing that I wanted to highlight because I have 3 minutes and I want to use it. Is one of the other studies that I really like that we did is we did the first LGBTQ longitudinal study. And in PRIDE with UCSF, we supported them and a number of other fantastic researchers. One of the things that was really interesting, and there's a lot of case studies in this study for us, one of the things that came out is that when we were testing the app, we had these features because we got market research, and this is what the community told us they wanted to do. And when we put the features out, we sort of said, okay, great, here they are, let's test them. One of the features that most people on our team really didn't think was that cool became the most used feature in all the usability testing. And so the team kind of said, huh, like that's really interesting. I really didn't think that that was going to be like the highlight of this thing. But all the patients were saying, oh, that's great, but I really love that feature. And it was this Reddit-style social posting feature. Okay? And over and over again, we kept hearing that. So long story short, in this study, one of the coolest things that came out of PRIDE is not just that it's collecting amazing research, giving amazing content and education to patients, giving a lot of value, because there's 16,000 people actively engaging with this every day. So this is a great case study, and it's not just been around for a month, it's been around for a year and a half. The other thing that I would say that's been really interesting is that one feature continues today to get the most love. And this Reddit-style posting means that what we were hearing from patients is that they had questions that their doctor couldn't answer, or that they were maybe not, they felt a little embarrassed to ask their doctor. And they wanted to know if anybody else had that problem. And they didn't really have forums to go on to do it. So they go on the app and they basically put in the question like, is your doctor, have you guys have this question? And they put that question in, and people in the community would up and down vote it or make comments to it. So they kind of help them learn something. The most upvoted request actually became responsive design in the research study. So as they were doing the research study, they would say, wait a minute, 12,000 people just asked us this question and want to know the answer to it. We should do research on that. That's just as important as the outcomes I'm trying to get. And so they would pull out that question, find the ePro, whatever was needed, get the IRB approval, put that back into the app, ask the question, instantly get the data. Guys, that's responsive design clinical research we've never been able to do before, and you're doing it for like $12,000. Like, that's what's changing the world about digital health and gets me really excited. So I'm going to end with that. There's a lot more here. We've got sort of open session. I know you've asked some questions. I want to hear all of them and help you answer or work through some of the challenges you have. But thanks for letting me yak at you for an hour and kind of walk through all these principles. I know it's a lot of content, but I think it's important that you understand sort of what's the context, how do you think about design and some of the pitfalls that people are falling through, and then when you think about functionality, APIs, and how these things actually work when they get done. Those are the 3 components you really need to work through when you're trying to develop anything in mobile health. So hopefully that helps you guys. Thanks so much for having me. I really appreciate it. And let's open for questions. So what you got?
I have a thought or just questions around the standards bodies around the development of the different mobile environments and that kind of thing. And how is that handled? Is there a standards body that applies to all of them, or are they device specific?
Yeah, so the regulatory bodies are there's a lot of them. When you have, I would say it starts with your IRB and EC. So you're in EC, because I'm thinking globally. Let's focus on the U.S. When you think about the U.S., when you're building something, you're thinking about what are the principles of patient privacy, and anything that's patient-facing needs to go back to your IRB. Thank you. So you're thinking about the IRB first. Really, when it comes to regulations, which is kind of where I'll end the answer, when it comes to regulations, there are a number of regulations around regulated medical devices and other regs, but they're all device-focused. What I would tell you is that the depth you have on the device-focused regulations helps you understand what's not covered in them, which is where a lot of mobile health falls. I would tell you 95% of all mobile health doesn't fall on a medical device or a registrational device. Okay. space. But most of the guidelines have come out around those because they're making treatment decisions, drug decisions, dosing decisions, where these are a little bit more actionable and behavior, and so they don't meet the criteria of those regulatory standards. The bodies that are influencing these are all over the board. I mean, from FDA to EMA to HRQ to, literally, I think I'm writing a guideline for how to do mobile health for almost 3 or 4 of these groups. And actually, some of the writing even overlaps itself because I think everybody is trying to deal with it with their own grants. Like even the CaDHRI work is doing the same thing. So everybody's trying to deal with it in their own way. But it's not that they're regulating it. It's that they're providing guidelines for it. And they're taking lessons learned. Because remember, we're still only talking about a net of less than 400 studies that were initiated recently. So it's not like it's been this huge sort of phenomenon yet.
And what about just UIs and things like that? I mean, when you come up with different ways of handling, like when you want to do a drop-down list, you do the little roller thing and that kind of thing. Where do those standards get defined and how do they evolve?
Yeah, there's no regulatory definition or standard for those. What I would tell you is that those are sort of different companies doing different because they feel like they have a feel on what the best is. But either way, just know that whatever you choose to use, that's part of your IRB application is actually showing form factor. And what I would tell you too is a lot of times in IRB, and I've seen this, honestly, I've seen it too much, is like we looked at like where you click a little scroll bar and you scroll down with your thumb, and they were trying to do it in a patient condition I can't tell you about that has an issue with their hand, and so they actually can't scroll that way. And so even though the IRB would approve it, it was really dumb to do, but there's no regulatory guidance that says if you build an app for this population, don't make a scroll bar that you scroll with your thumb. Does that make sense? Like that just doesn't exist, and I don't think it probably will for quite some time. What you got?
Yeah, can I just ask
Of course.
a dumb question?
No dumb questions.
So what is usually, how long it usually take you to, from the beginning, get a contract signed and start to plan the design until final, that is done?
Yeah, 1 month to 2 years.
Oh, so it varies.
Yeah, and the reason it varies is 2 things. One is the institutions are usually the whole, like I can do stuff really fast. It's usually, remember I work with pharma and large health systems. Some of those people want to go through MLR reviews and legal regulatory reviews for like 6 months. So it depends on, it's usually not getting through the process steps we talked about. It's usually getting the approvals. Hence why a good business case and a good measure up front clears the road for you to get things done quickly. And I've definitely seen some people that we historically know are very slow get things done really fast because they got everybody on the bus really from the get-go. And so that's been a big help to some of our projects. Meaning like CEOs and CIOs and people's last names are on the company banner show up to the meeting because they want to push it through. That's, so in absence of that, it's usually, your problem's not going to be the tech and the design thinking. Problem's going to be your institution or getting through your company.
So actually the design part and testing part is usually 1 month.
Oh, yeah. Yeah, most sims, I would tell you a good sim that has sort of 2 UATs built into it, you're usually talking 3 to 4 weeks. If you take your time, get it right, and if you got a big team. If you have a small team, there's no reason you shouldn't be able to do that in 2.5 weeks. Yeah, go ahead.
How do you get funding for like a new app that if you think someone has a great idea, and how does he start?
No, you don't. I'm just kidding. No, there's funding. So I am not the expert to talk about how to get grants and funding. I get stuff because I go out and I tell people I can do things for 1/6 the cost. You should buy it, and then we deliver, right? So that's a good case study to get money. But I do business to business work. If you're gonna do sort of grants, I'd give you a couple ideas. So one is, my number one idea is if you've really got a good idea and you think there's something to it, you should do a Kickstarter for it. That's where I would start. If the second place I'd start is there's a number of accelerators. So if and I ran a digital health accelerator for a while. They're really fun to do. But accelerators are where they come in, they work with a startup on an idea. They usually give them a $25K kicker to get started, and they give them a little bit of expertise and coaching, and they get them through that process. And there's actually a number of accelerators in the Triangle area and in Durham that are great, and they do between 15 and 25K kickers if they like your idea and if they sign you up. But you go through essentially a 3-month program to try out your idea and to get it up and running. So it's sort of a low risk, low spend, but they'll take a chunk of your equity. So they'll own a chunk of your company. But if you have no money to invest in it yourself, you don't really have any other options. The third option is if you a lot of times people think that they have to have the app, to go get funding. And again, I would tell you, I've gotten tons of funding in the past with clickable prototypes and beat out a lot of other people on funding because we had a really good clickable prototype. Because remember, people are visual when it comes to mobile. So when you say like the app's going to do this and it's going to do that, people are like, oh, okay, great. If you go say the app is going to look like this, and you pull out the sim and you show it to them, they go, oh wow, okay, that's great. Like it becomes real. And so I think that whatever you're trying to do, spending time to not just write something up or a business case, actually building a clickable prototype yourself is critical. And I wouldn't go ask anybody for money without one at this point.
So apps or like, unlike devices, you can't patent them probably. How do you protect your ideas if you think, you're going to pitch it to someone else?
Yeah, it's actually not true. You can actually patent them. There's different types of patents. I'm not an IP lawyer, but I play one on TV, and so I'll tell you that you can definitely patent a lot of process components. You can actually wrap IP around particular instances or different process flows that happen in the app. So remember the active tasks I showed you, like the walking tests and those? Technically, if Apple hadn't done them in open source, and if I had built them, I had a choice. I could have given them an open source and put them in GitHub, or I could have patented that process and the way it form factor and the way it happened, and every time you want to use my thing, I charge you for it, like a freemium model or a subscription model, and that's actually how most people are patenting using tech today. So don't think about patents like this monstrosity, it's like I'm going to build this platform and patent it. Like those days are gone in my opinion. What you're talking about is what's IP I can put around something. And remember, IP is gained by data, insights, and what it wraps into. So if your platform is a one-hit wonder, it's got like one little function to it, I wouldn't go patenting that because you're probably going to lose. But if you have something that fits into an overall structure that gives you value and that somebody else could, it would be hard to replicate, but they could, that's something you typically want to look to patent. And you absolutely can patent different things in mobile. You can't patent an app that looks like Snapchat, which is what a lot of people are trying to do. And they're like, well, you can't patent mobile. I'm like, it's because you're patenting the app or the way it looks. You're not patenting the technology that goes behind it to make it work. Remember, Snapchat, Uber, 17, 50, billion dollars. It's not just an app. The front factor has little to nothing to do with actually what those things do. The back end for those things are ridiculous. And those, they have lots of patents for how those work and construct. Does that kind of answer the question a little bit? It's a tough one. I'm not saying that's a thorough answer. It's just a answer. Yeah, go ahead.
Kind of going back to Faye's question about IRB, if we're developing an app for mostly thinking about how the customer is going to use the app, and then we're doing data collection in the background, what is the consumer information process for that? Do we have to tell them what exactly we're collecting and for what purposes?
Yes.
If we're not doing IRB?
If you're not doing IRB, so you're doing like a patient
Like if
support
it's just
program,
consumer-based,
it's
yeah.
consumer.
Yeah.
So two things I tell you: if you're collecting research, if you're doing a patient support program or an aftermarket program, but you're collecting, if you're collecting PHI without the PII attached to it, so you're collecting health information, I would actually encourage you to actually look at a waiver from your IRB, especially as a health institution. Because the reality is you might be doing research, but you can call it whatever you want. But if you're collecting data and doing research on it, you're technically falling into research regulations. So I would talk to your IRB about that and if they need to give you a waiver for it. And that's pretty standard. When you collect that data, the good news is when you're in a commercial environment, the restrictions are a lot less. There's no 21 CFR Part 11, no high trust, no HIPAA, no safe harbor. Like there's a lot of things you don't have to do. And I say no HIPAA because there's actually a ton of commercial programs that actually don't follow HIPAA. They let you consent into giving up your HIPAA rights, basically. I would not encourage you to go that direction. I would say that's a stupid idea in a technical term, but there are companies and things that are out there that are doing that. And so whenever you're thinking about data, just remember that irregardless of what the regulatory requirements make you do, if I sign up for your app, you are always better to very openly say, these are all the specific things I'm capturing from you. Is this okay? And what we've done is we've built in options for each of the functions. So remember, I'm doing studies that have like a genomic lab. I'm integrating their EMR. I may be doing geolocation to find out if they're like drinking 2 Starbucks a day. Like I got things I'm trying to collect. But as a patient may say, hey, listen, I'm cool to give you my genomic lab. Cool for you to take these 8 variables off my EMR, but I don't want you to know where I'm driving. You don't want those to be one button so that that patient isn't viable for your study. You want that to be 3 buttons so you can still collect data from that patient, but know you're just not going to get this factor. Make Make sense? So I would think about things as not consenting, but think about them as opting in. So a principle of continuous opt-in is really important, which means I'm opting you in, but I'm continuing to remind you. You guys see this today, right? You're getting this email because you signed up for X. What you don't know is behaviorally, when you read that, you feel more comfortable that the email was not targeted at you, it was for you. And there's a reason that principle works. And so opt-in and continuous is important. Does that kind of help? Yeah.
What categories do you see as the drivers of the mobile app development? Like pharmas or healthcare institutions or consumer products? Or like who are you getting business from? Not
Everybody.
in a broad,
I'd say everybody, but they all want to do different things with it. Let me give you I'll answer it a little bit different of a way because I would say it's everybody. But here's what I see happening, which is what I'm trying to fix, is that pharma comes in and does research, and to do a mobile health study or a mobile health like sub-study in a protocol is like peanuts. It's super cheap. Like finances is not the issue for signing that thing up. On the academic side, I have tons of, like I'm working with 3 academic companies right now, and I have 7 people coming to you for a proposal from the same institution. Okay, it's not UNC, it's other people. And they come into me and they're saying like, I all want an app, I want to do all these things, and I want it for X price. And what I'm trying to say is actually the way that pharma does it, where they get a central platform and deliver things, because they can deliver that thing in 10 studies at a much discounted rate and get the rigor they want, is the same things I think academics and institutions should do that they're not. So they're still one-off getting apps and development. So actually, if I went as a vendor procurement person and went to UNC or name the institution, I think I could say, hey, guess what? I could say to the entire institution $25 million tomorrow. You watch me. Because they're not consorting their efforts. So that's why I like what CaDHRI is doing, is bringing people together. Because when they understand, like, oh, there's something I can do centrally, that is actually where the effect comes in. Because remember, like 80% of mobile health app is the same principle. Whether you get like some kid or one of these design firms to sell you a slide deck and build something for you, if you don't standardize and repeat it, you don't have that experience, you're going to get junk and you're going to pay for it. And so the thing that I'm passionate about is if we standardize this stuff, we'll actually be able to make mobile health standard and normal, and we'll be able to do it at a rate that's normal. And then what we'll be able to do with the industry is move from not doing things the traditional way, but doing them a mobile first way. But really, remember our industry, healthcare. What's the number one thing we're concerned about? Is it outcomes? Is it patient experience? It's money. It's money. It's cost, right? And so let's not be naive to know that we're working in businesses, even though we may have different objectives. The way you get your objective done is figure out how you decrease the cost first, and then get the outcome and the better patient experience second. That's what I think.
Yeah, I fear for that a little bit at UNC, moving increasingly to a model where each department is going to have its own, basically, profit and loss, and it's not going to be as many interdisciplinary things. So I think CaDHRI's fighting an uphill battle on that regard. But
Yeah.
We're fighting a good fight. Hopefully we'll pull something together.
Yeah, and you're not alone. Like these other institutions have the same problem, and they're trying to do the same things. But I just think that the reality is we have to make these mobile health needs to be more robust than this again, because we're getting compared to Disney and Amazon. But at the same time, we don't have the kind of funds like pharma and consumer companies to spend. So we've got sort of this like we want the world, but we can't afford it. And so we got to figure out how to balance that. And I think that's kind of where the industry is at today. So regardless of the economic buyer, I think that's the challenge that we got. What else you got?
What are the tools that you really like? You mentioned was it Envision for clickable prototyping?
Yep, I like Envision. I used to use iRise, but it's really tough to use. It has a pretty steep learning curve. I really like Envision. I mean, there's a number of other ones. That's just the one I like the best. There's other, when it comes to like design, so Lucidchart is, if you guys are, like Lucidchart's my best friend. Like I'm probably in Lucidchart way more than anything in the world. Just because when I build schematics or diagrams or do my own design thinking on like how to do something in a platform, I go to Lucidchart. That's just the way that I get out of my head an idea into something. And it's quick and easy. So a Lucidchart, Lucid chart. Yeah. So it's like it's almost like Visio, but a lot easier and cheaper and easier to manage. Yeah, and it's not meant for like organizational charts. It's meant for like mapping out stuff. the other method that I really like, and I kind of like, every time I say it, I feel a little bit like I'm a hypocrite, but I really like turning off my computer and my phone and writing stuff on my whiteboard. I'm just a whiteboard guy, because I just think that, again, once you get in those documents, you just naturally, a lot of people in this space are perfectionists, so we start getting into, oh, well, let me move that line, and I want to make it purple, and what we do is we lose the train of thought. It's kind of like, if you wake up in the middle of the night, you don't write something down, it's like, poof, it's gone. It's the same principle in design thinking, that the more you can just freeform and just get it all out and then organize it later, the better I think you are.
How do you organize, how do people organize to actually work on these projects?
They look more like Scrum teams. That's how they look. So a very sort of lean and agile approach. Again, because we're always building our platform, but a platform is meant to sort of take out of our heads and put in the platform to make it repeatable, so that your team gets to focus on the cool custom elements. They're not focused on like moving widgets and donuts around. Like that's what, when you go into development, if you say like, here's your code, you realize like so many people are building these custom apps every time. They're just sitting there like slugging through code every single time, racking up a lot of hours and spend to build the app. When what you really want to do is standardize the way you do that, so you can spend time on the elements that you say, this is an innovative piece I want to do, or this is something novel I want to spend my effort on. You don't want to spend your effort on like, where's the screen need to go, and should I have a consent module and things like that. So our teams are sort of focused on product, but then also they're in any kind of project, it's a little more Scrum. So you put together these different experts on one team around this project.
Thank you very much.
Thanks.
Yeah, thanks. And with that, we should probably wrap up and move to the social part. You all can sit and chat with each other and talk to John if you have any questions.